Hello. So today we're going to be talking about adult growth and development and end of life. And I always say that these topics aren't exactly the most uplifting of topics, but the reality is that everyone is going to go through growth and development, and everyone is going to experience some facet of end of life care as a nurse, no matter where you end up working. So, very important topics, although maybe not the most happy. And no matter what you've experienced of these in your own personal life, we want to make sure as you're studying and looking at these that you're really looking at them from the perspective of a nurse. All right, so where are we at health-wise in our 20s and 30s? So physiologically, hopefully we've reached our full physical growth capacity. Everything's functioning. Thinking-wise, hopefully you're not as impulsive as you were when you were 15, more objective, more realistic in your thinking. Psychosocial-wise, if you remember your Erikson's stages, he, says, okay, by your 20s and 30s, you're moved out of that, kind of finding your identity stage, and now we're really trying to find our person or our group that's kind of outside of your parents. So maybe if you kind of forgotten or don't remember your Erikson stages, review those. But in our 20s and 30s, we're in that intimacy versus isolation stage where we're trying to find our group, our family outside of our parents, so that we aren't feeling isolated, basically. Then, of course, as many of you are aware, in our 20s and 30s, we're working, many people, not everyone, are working towards establishing a career and a family. So when you have a patient that is a young adult, 20s and 30s, you always, of course, want to do a thorough assessment and figure out whatever their specific kind of health promotion needs are. But this slide just includes some common issues, health issues of patients in their young adult years. So certainly want to make sure that we're promoting health still, that, even though their mom isn't making their appointments anymore, that they are making their own appointments in their 20s and 30s to the dentist, eye doctor, etc., whatever. We need to keep those regular exams going. Injuries, certainly a leading cause of death for our younger adults. So as a nurse, you kind of need to figure out, okay, what is this person doing that may lead them to have an injury? Is it that they're, really into snowboarding or, I don't know, skydiving or something? Figure out what maybe would lead them to have an injury, and then figure out ways to ensure safety with those activities. Of course, most of us are driving, and that's our leading cause of injury. So always want to encourage safe driving and driver's ed if you can. Substance abuse and injuries, of course, go together because substance abuse a lot of times can increase risk-taking behaviors. Hopefully at this age, people realize the relationship between driving and injuries, but I think sometimes we forget how dangerous driving really is. And then, of course, we want to include education on over-the-counter and prescription drugs, and how those can cause many issues. And people can develop issues with those things, of course, in their 20s, at any time in life. It's not just, you pick it up when you're 17 and then it becomes an issue. People can pick up issues with substance abuse at any time. With suicide, of course, the big safety thing with nursing that we want to keep in mind is that if somebody is experiencing any sort of suicidal ideation or thoughts or anything of that nature, we have to make sure that they are safe and make sure that there's an immediate referral to resources if we notice any of those signs. With pregnancy, the big thing really with pregnancy is just to encourage prenatal care. And I don't need you to know what prenatal care, what all that entails, but basically just that they're seeing a doctor, prior to the birth of their child. STIs, so we want to encourage safe sex practices, make sure, that people are able to recognize signs and symptoms of STIs, sexually transmitted infections. With in regards to women, encouraging an annual pap smear and pelvic exam, and then for both men and women, an HPV vaccine, so human papilloma virus vaccine. And then with nutrition in our 20s and 30s, some people are really great with nutrition, not an issue. But commonly, as we're, busy trying to raise our families and get our careers going and et cetera, busy, perhaps our diet is not on the forefront of our brain. So make sure that we're trying to encourage still those healthy food choices, and also monitoring for any eating disorders. All right, so what starts happening in middle age? I think this is when things start to get a little depressing, although there are a lot of people in their 40s to 60s that I think are healthier than I'll ever be. So, if you take care of yourself, then maybe these things aren't so bad. I don't know. That's what I'm going to tell myself. Anywho, so physiologically, we've got just in general a gradual decline in functioning, according to your book. So I included a table from Taylor that includes essentially what is going to start declining and functioning. And I think if you look towards the right at all of those bullet points and read through them, they make sense, and they're not things that you would really need me to explain to you. I think we all know that wrinkles start appearing as you get older, and that, fatty tissue may be redistributed, etc. Gray hair. I don't think you need me to tell you those things. I did bold a few things that I think are important just because they can lead to other health issues, and any time we're worried about heart stuff, that's always going to be of large concern. So cardiac output begins to decrease. That's important to understand. And then a loss of calcium in the bones predisposes a perimenopausal woman to injury. And then again, at the bottom there, I have hormone production decreases resulting in menopause and andropause. So changes in hormones, and then cardiac output are your big, declining and functioning things that are of concern. I think the other ones are still of, interest, but you probably know those without me telling them to you. Other big things physiologically with somebody in their middle adult years, it's going to be that recovery from illness takes longer, and there's going to be an increase in chronic illnesses. And those two things kind of go hand in hand, right? Because, of course, if somebody has a chronic illness or multiple chronic illnesses, if they get pneumonia or some sort of acute illness, it's going to be that much harder for them to get over that issue. Psychosocially, so in Erikson's stages, we're in generativity versus stagnation. So if you remember what that means, that's going to be that, at this point, you've done everything you kind of wanted to do for yourself. You had your family, you have your career, everything's just going so wonderful. And so now you're going to say, okay, my time is limited. What can I do to make sure that I leave this world a better place? As opposed to just saying, no, I think I'm still going to focus on myself and, buy that, Corvette for myself and have a midlife crisis and not think about anybody else but myself. So generativity, what Erikson wants is for us to, in the 40s and 60 to 65 is be thinking about the next generation. And then, unfortunately, by our middle adult years, maybe people are starting to think, hey, lived over half my life. The end is coming. All right, so how do we slow down that gradual decline in functioning? So we're going to encourage for our middle adult patients a lot of the things that probably all of us have heard before. Healthy eating, regular exercise, limiting or eliminating those vices such as alcohol and smoking, and then of course still your regular kind of exams, going to the doctor, dentist, eye doctor, etc. And even though those things maybe seem so simple, right? There's only 5 things on there. We've all probably heard it before, either from our own doctor or other classes or whatever. Somebody who is really set in their ways or maybe hasn't been doing these things for the entirety of their life maybe won't be as open as you think you would, or as you think they would be to these things. So make sure you're being, using that therapeutic communication and being empathetic and figuring out maybe what barriers they have to adopting some of these practices, and not just assuming that they know, like, oh yeah, you need to eat healthy. Make sure they understand, what does really healthy eating look like for them, and how do we make those things work for them? How do we encourage regular exercise without it being overwhelming to them? So tailor it to your patient. Don't just say, okay, yep, you gotta eat healthy, you gotta exercise, you gotta get rid of all your vices that you've been doing for, the past 20 years, and then you gotta go to your doctors and leave it at that. Make it personalized and make it work for them. A couple of screening things, or other issues that we're going to be starting to have a little bit more concern of when our patients are getting in that 40 to 65 range, are things such as breast cancer, cervical cancer, prostate cancer, and testicular cancer. So if you'll notice, these are things that are dealing with our reproductive organs. So the big thing when we're talking about these types of cancers is that we want to make sure that people are doing adequate screening, because anytime you're talking about cancer, the sooner that we can catch it, the better. So I'll have a sheet for you, a table for you guys that has some recommendations for screening that might make it a little bit more visually pleasing to you, or easier to memorize. But with women, we do want to start encouraging mammograms every year at the age of 45. And then cervical cancer is a concern. So again, we want those pelvic exams and pap smears. With pap smears, for 21 to 29-year-olds, it's actually every 3 years, and then every 5 for women 30 to 65. I know that there are some people out there that may say, oh, well, my doctor wants me to have, a pap smear every year or whatever. That's a common thing. It depends on your own situation, and depends on the doctor and what the doctor, what's going on. If you've maybe had an abnormal pap smear in the past, they may want you to have more frequent ones. But in general, every 3 years for 21 to 29, every 5 for 30 to 65. And then with men, a digital rectal exam starting at age 50, and we want those done every year, and then a monthly self-exam for testicular cancer. And then I didn't mention, but a monthly self-exam for breast cancer as well. Okay, so some more monitoring and health promotion for our middle adult friends. So if you'll notice, again, we're worried about cancer. So cancer is a big one that we're worried about starting to monitor in the middle adult years. So colorectal cancer, want to start monitoring for that at 45. And there's lots of different methods out there. You guys have, I'm sure, all heard of, colonoscopies monitoring for colon cancer. There's also, fecal occult blood testing that can be done, or they might do, a CT or something like that. Really, what we need to know as nurses, you need to do some sort of monitoring. So whether the provider is going to figure out what that, what's appropriate for the patient, but we need to encourage just that we're doing some sort of monitoring for colorectal cancer. And then once somebody gets over the age of 76, it may not be necessary. And again, that's a discussion that the patient will have with the provider. Skin cancer, again, along with either, self-exams for testicular cancer or breast cancer, we want to be encouraging really anybody of any age, but especially our folks that are that 40 to 65 range, to be doing a monthly self-exam for skin cancer. We have bone density. So women that are under 65 with risk factors, so that may be, as I have on there, a fracture after age 50 or height loss. So under 65, menopausal and with risk factors, we want them to start bone density screening, or any woman that's over 65. Men can typically wait a little bit longer, so any man over age 70, or if they have risk factors, as mentioned, we're going to start bone density screening a little earlier. Immunizations, so Tdap, so booster every 10 years. Hopefully they maybe had one dose at least in their younger years, but if not, we definitely want to encourage that. MMR, as it says there, one dose, who previously received less than 2 doses, or are at increased risk. Influenza, pneumonia, and shingles. So with these, I kind of just like to mention these are more voluntary. We don't necessarily, I feel like people are more likely to kind of say, I don't need that, or I don't need a flu shot, I don't need a pneumonia shot, I don't need a shingles shot. And as we know, they're really important, and we should, if at all possible, encourage our patients to get these more optional, if you will, vaccines. So flu shot, of course, once a year. Pneumonia is typically a one-time thing, but sometimes people do get another dose depending on the type of vaccination. So that would be something that they need to discuss with the provider. And then a shingles vaccine can be after age 50. All right, so moving on to things to consider for our patients that are 66 and older. So I think maybe sometimes we have this thought that, once you get older, things really slow down, and everybody that's retired has their life figured out, nothing's really going on. But the reality is there's a lot of changes that occur when somebody's an older adult. Maybe they're experiencing changes to their health that need to be adjusted to. Maybe they've had a loss of a spouse. Maybe they're not functioning as well as they used to, and now they have to move into a retirement home or assisted living or a nursing home or something. Maybe they retired and now they're living on a fixed income or a lesser income. There's a lot of changes that go on in older adulthood. It's not just sitting around watching The Price is Right all day. So we want to take into consideration those changes and make sure that we're being empathetic to those and supportive of those. Health-wise, so our older adult patients can sometimes have atypical responses to illnesses and different types of medications. So you want to keep that in mind when you're assessing them. And I always use the example of lorazepam or Ativan, which is our common benzodiazepine, which typically when given to somebody is going to cause, sedation, decreased anxiety, etc. Sometimes when you give an older adult patient Ativan, that's not the case. They go into overdrive and can be even more combative or restless or whatever than you'd ever expect. So again, sometimes older patients can just have atypical responses, and that atypicalness is to be expected. Psychosocial. So if we're thinking about Erikson's stages, if you remember, this is, now the kind of the last stage, ego integrity versus despair. And what Erikson wants our older adult patients to be doing is saying, okay, yep, I had a really great life. I did everything that I wanted to do. I'm happy with how my life is gone. I am ready to die, basically, versus looking back and saying, oh my gosh, there's so many things I really wish I would have done. I really, hate that I didn't do this, X, Y, Z. And so, having those kind of unfinished, upsetting feelings. So again, Erikson says we want to look back and be happy and be ready to move on to the next, stage, which is death, basically. Other things going on that can really affect the psychosocial status of our older adult patients are going to be things like changes to job status. So retirement can be a really great thing, but can also kind of maybe lead our older adult friends to say, what do I do now? And have some maybe issues with income as well. Driving. Not everyone is safe to drive at 85. So potentially this can cause some issues with, feeling a lack of independence if somebody isn't able to drive anymore, especially, if they're not able to go to bingo every Tuesday or something like they were once able to, or whatever. Can cause some social isolation. So changes in driving can be something that we want to be aware of. We want to make sure that our older adult patients are safe to drive, but that if they're not able to drive, that we're looking at how that is affecting their life. And then that kind of goes hand in hand with isolation, that if somebody's not able to maybe drive like they once were, that they may be stuck at home. Maybe they don't have that really good family support or friend support. So we want to make sure that we're not forgetting about our older patients and that we're connecting them with any resources and preventing that isolation, because that is a huge, huge issue, and frankly just really sad. Cognitive wise, so definitely can have some cognitive decline, of course, as our patients get older. So we want to be doing some mental status exams, a mini mental status exam, just making sure that you're not kind of assuming that somebody who's an older patient is alert and oriented times 4. Make sure that you're actually assessing that, because some people are really good at hiding that they don't know what's going on. Dementia, delirium, of course, both issues with our older patients. So with dementia, that's kind of just your gradual neurodegenerative disease. Alzheimer's is going to be issues with nerves, that they just can't transmit signals very well. There are some medications out there that can help with Alzheimer's, not necessarily cure it, but at least slow it down. So diazepam or Aricept is one of those. Exelon can be helpful. Also, because sometimes when you have anything nerve related or brain related, these can cause changes in behavior and feelings. So antidepressants are commonly given, and possibly some behavioral things like your benzos or possibly Haldol to kind of calm the patient down if they get really, really agitated or restless. But those are, try and save those for extreme circumstances. Delirium is a temporary state. So with dementia, we've got, confusion and just kind of lack of neurological functioning that happens gradually. Delirium is abrupt onset, acute, it's reversible, it's usually caused by something else going on. So delirium, like I said, our older patients have an atypical response oftentimes to illness. So like urinary tract infection, very common. Somebody who's 20 who has a UTI is gonna maybe just have, pain or, those typical symptoms, whereas somebody who is 80 may go off the rails, be completely confused, not know who they are. Maybe they normally are ANO times 4, but when that UTI is in full force, they don't even know, their own daughter. So in that case, we're not necessarily, we're going to treat the UTI, and then that delirium will go away. Big concerns really with our dementia patients and our delirium patients is going to be safety. When you're thinking about, how am I taking care of this patient as a nurse? Really worried about safety, because these are patients that are going to be kind of impulsive and not have those safe thought processes of mind. All right, so some health changes, expected health changes of our older adult patients. I have on here a table from Hinkle that kind of goes into a little bit more detail with expected changes, but on your PowerPoint I've kind of included ones that I think are most important or most prominent. So when you're looking at these, when we say, okay, we need to look at this stuff from the perspective of a nurse, we need to think, okay, I know somebody has a less efficient heart, but what does that really mean? So again, if I know somebody has a less efficient heart, cardiovascular wise isn't maybe going to work as well, how does that work for them? So it might mean, okay, this person is at greater risk of syncope. This person is at greater risk of, an MI. What does that, put them at risk for? If I think about respiratory wise, they've got decreased gas exchange, they've got decreased lung volume. Okay, well, I know they're going to be at increased risk of respiratory issues. They're going to be at increased risk of pneumonia. So I need to make sure as the nurse that I'm encouraging, respiratory hygiene. So incentive spirometry, monitoring their O2 saturation maybe a little more closely, making sure that we're doing really good respiratory assessments. If I know that those are going to be issues, what does, to critically think, you need to be thinking, what does that mean for me as the nurse? integumentary. So if I know that somebody is going to have really thin, dry, fragile skin, I know, okay, as a nurse, I need to be monitoring for skin breakdown, skin tears. I need to be making sure that I'm turning them every, 2 hours at minimum. Reproductive wise, if I know that, intercourse is painful for older adult patients, or that they have, issues with delayed sexual response, okay, I know that that maybe is going to cause some relationship strain or something. So I need to be assessing those things and making appropriate referrals if those things are issues. Musculoskeletal decline, okay, I know that I need to be worried about safety, or maybe thinking about, okay, what are some things that we can include in therapy or exercises that we can do to kind of build up somebody's musculoskeletal system. Genitourinary, so increase urgency and or frequency. So this person, may be more at risk for urinary tract infection. They may be more at risk for, episodes of incontinence, and then that may be really stressful for them. One thing that I really want to point out is that incontinence, although it's common, it's definitely common, it is abnormal. So somebody who's older, greater than 66 or whatever, anybody who has incontinence, we don't just say, oh wow, that's a bummer that you're incontinent. I don't know, that just happens a lot, so I guess you're just gonna have to deal with it. That's never gonna be our response. We're gonna say, okay, you're having episodes of incontinence. Let's dig a little deeper here and figure out what we can do to address that and hopefully manage that, maybe fix that. So it's common, but it's abnormal and it should be addressed. Gastrointestinal, so if we think about somebody who is older, they may have issues with decreased thirst, taste, smell, which of course kind of takes some of the joy out of eating. So they may not have the best nutrition. They may have a decreased appetite, decreased intake, which can lead to issues. And then delayed motility or slow emptying may lead to more issues with constipation and straining, which we want to address. Maybe we need to recommend, more fiber, more fluid intake, maybe a stool softener, etc. Nervous system wise, so we've got decreased brain and brain volume and cerebral blood flow, reduced nerve conduction. So of course, all of those things can increase their risk of confusion and those issues with dementia and just in general neurofunctioning. So we need to be assessing for those things, figure out how that's affecting their safety and just their day-to-day life. And then lastly, we've got vision impairment as common. So again, thinking safety, falls, driving, are they able to, organize their medications appropriately? Are they dosing themselves twice because they think, their blood pressure medication is their diabetes medication or whatever? So safety is another big issue there. All right, so some more health promotion of the older adult. So what can we do as nurses to help our older adult patients? So definitely want to be doing a thorough assessment for any issues. Of course, we went over in the last slide some common issues and some common things that happen, but everybody is different, and you always want to be doing a really personalized assessment to figure out, okay, what is really this person's issue? And always the earlier that we can catch something, the better. If the patient has sensory aids, we want to make sure, such as hearing aids or glasses or whatever, we want to make sure that they are functioning and that they're actually using them. My grandpa has a hearing aid that he never uses. So I always have to say, Grandpa, put in your hearing aid. You can participate in this conversation a lot easier with your hearing aid in. But we actually found out that there was a setting on it or something that was off that was causing everything to be so loud that it was really miserable for him to have it in. So, maybe it's something that can be adjusted that will help them actually use whatever aid that they have. Provide nutritious foods that are appropriate for a patient's ability to chew. We can certainly have dental issues as patients get older. So want to provide appropriate foods. Also think about, how they're functioning and if they're able, to really realistically chop fruit or to, cook nutritious meals. Maybe that's an issue for them that we need to address, or maybe it's an income issue that needs to be addressed. So think about what the barriers are for nutritious foods and an appropriate diet. Encourage sleep hygiene. So, we don't want them sleeping necessarily in their recliner from 10 a.m. to 2 p.m. and then being up at 1 a.m. or whatever. Try and, like a child, have a consistent routine for them if possible. Elimination issues. So yes, we know that those are common, so we want to be assessing for incontinence and addressing that if that's a problem. Assessing, for constipation, and just in general making sure that they're not having elimination issues. Safety wise, so we want an uncluttered environment with adequate lighting. So if we can have, get all the rugs out of the room or out of the house, make sure that there's, grab bars or safety bars in the shower if that's what they're using, or a shower chair if that's possible for them. Make sure that the environment's safe. Adjust pace of care to match patient's functional ability. Again, that's just kind of going to be dependent on the patient, but we want to make sure that we're helping them maintain their independence if possible, and letting them do everything that we can, but also adjusting their care to whatever their abilities are. And then, of course, involving the patient is always important. So see what their priorities are, see what they're, worried about or upset about, and then figure out a solution together.